Hello, my name is Erin Cox, physiotherapist. Today I'm going to talk to you about the biomechanics of the elbow. So we'll just share the screen. So biomechanics of the elbow complex. So don't forget, when we're talking about the biomechanics of the elbow, we're going to be talking about three joints: the humeral ulnar joint, the humeral radial joint, and the proximal radial ulnar joint. The humeral ulnar joint. Now let's just look a bit at the planes of the joints. So the humeral ulnar joint, on the humeral end, we have a convexity in the anterior posterior direction, and the ulna is a concave surface. So it's a bit like a bowl. So it's not a flat surface. So we're going to look at more of the flat part in the middle here, like being at the bottom of our bowl when we go to do our mobilizations. The humeral radial, you can see that the plane of the surface is perpendicular to the long axis of the bone, where that was not the case with the ulna. So if you want to traction a joint, in which direction should I pull? At a right angle, so 90 degrees to the plane of the joint surface, or parallel to the articular plane? At a right angle, we want to pull at 90 degrees to the joint surface. So again, if we took our humeral ulnar joint, and it's more like the bowl, and here we're going to take the bottom of our bowl, can you see that we won't be along the long axis of the bone if we want to do a traction? Whereas if we're in the humeral radial joint, we can pull along the radial long axis of the bone. So if we're going to do the radius, we can pull along the axis, but for the ulna, it's going to go down a little bit posterior and inferior to it. So, and these are the directions here. So long axis of the radius, or a bit posterior inferior for the humeral ulnar. If we want to do glides, then I want to go anterior inferior for the humeral ulnar joint. And I always think about the joint surface being at about 30 degrees anterior to the long axis of my bones. So that's where I want to pull anteriorly to help my flexion, and conversely, more on the posterior, if I continue that line posteriorly and superiorly to help in my extension. So there we just see it again. So the humeral ulnar joint is the classification. It's compound and it's synovial. It's compound because all of the joints are within the same capsule. It's a modified cellar because, as we said, in the anterior posterior direction, it's concave, but because of the trochlear surface, it is convex in the medial lateral direction. So there's 1 degree of freedom, flexion, and extension. The closed pack position is extension with supination. The resting position is 70 degrees of flexion with 10 degrees of supination. The capsular pattern is more limitation of flexion than extension. So flexion is more of our functional. We want to be able to eat. So if it's limited more, then we're in our capsular pattern. Pronation and supination should remain full because the humeral ulnar joint is not involved in this movement. The normal envil and flexion should be soft tissue approximation because of our big biceps, and extension would be bony, the olecranon in the olecranon fossa. So as far as the mechanics, so can you see that on the medial side, we have a downward projection? So our elbow, it's not exactly horizontal, but it goes further down medially. So can you see that if I'm going to do my flexion and extension, that it's going to go around this axis? So for flexion, it's going to come more into abduction. And for extension, I'm going to come more into abduction. So flexion is going to go with adduction, and extension is going to go more with abduction. So as well, this is because of the anterior groove of the trochlea, which is vertical. And you can see in the back, posteriorly, it's more oblique. So I always remember this because if I want to eat my apple, I have to have my hand like this in flexion and adduction. And you can see that there'll be another movement going with that because we're going to be talking about supination and pronation that go as a conjunct rotation. So with flexion, we have a conjunct supination happening when all three happen at the same time, and that's my apple. And then in extension, it's going to be extension and pronation. So flexion, adduction, and supination to eat my apple. And then when I want to throw it away, I can extend, abduct, and pronate. The physiological valgus is about 10 degrees, or maybe a little bit more in women, or the carrying angle. So for flexion extension, it's an impure swing around a oblique coronal axis because of the medially going down lower. Flexion is combined with adduction, extension combined with abduction. The arthrokinematic, so the accessory glides of flexion are going to be anterior, but because we're doing a little bit of an adduction, and we know that it is convex on concave, we can also do a lateral glide. And it's certainly more in the end degrees of flexion where that little bit of lateral glide would help us to gain more flexion. And then for extension, it's going to be more of a posterior glide. And then because we're more in abduction, it's going to be a slight medial glide. And this would help us with extension. Also think of what stops us from doing these movements. So it may not just be articular. So for example, in the humeral ulnar joint, what constrains flexion? It might be muscle contraction of our elbow flexors, radial head impingement, posterior capsule tension, triceps or anconeus tension, and it could be the radiohumeral contact as well, or limitation. And constraints to extension could be an olecranon impingement, anterior capsule, or muscle tension. The radiohumeral ulnar joint now. So now we're looking at the radius and the humerus. So the articular surface, the capitulum of the humerus is convex and the radial head is concave all the way around. So it's an unmodified ovoid joint, but the mobility is restrained by its attachments to the ulna via the annular ligament and the quadrate ligament. So it's a synovial compound joint. It's an anatomically unmodified ovoid, but it will function as a modified ovoid because of those attachments. The degrees of freedom are two. At the radiohumeral joint, you can do flexion extension around a coronal axis, and you can do medial and lateral rotation or pronation supination, but that's like a spin between the head of the radius and the humerus. The closed pack position is 90 degrees flexion, forearm supinated to 5 degrees according to Kaltenborn, and mid-pronation and 90 degrees flexion according to Lee. The resting position is 70 degrees flexion, more of a capsular, and Kaltenborn says that there's an extension with forearm supination, which is more what we also talked about with, and we talk about with a closed pack. So Kaltenborn seems to always have his own ideas. The radiohumeral joint, again, the capsular pattern is flexion more than extension. We want to eat. So if we can't eat, we have a capsular pattern. Normal end-field flexion, soft tissue approximation for the big biceps again, and extension bony. Osteokinematics, the flexion extension, impure swing about an oblique transverse axis in a sagittal plane. Basically, it needs to follow the ulna because they're attached. And the pronation supination will be a pure spin about a vertical axis in the transverse plane. So it's going to spin. A terminal pronation supination does become a swing because of the conjoint movements. So the arthrokinematics, for flexion, we're going to do an anterior glide of the radius on the humerus. For extension, a posterior glide, supination, a lateral spin, or pronation, a medial spin. For the proximal radial ulnar joint, you can see there that the articular surfaces, the radial head is convex all the way around, and the radial fossa of the ulna is concave. The classification, again, is synovial and compound, as all of them are. Modified ovoid, functions as a modified cellar with the inferior radial ulnar joint. So don't forget, we move the radius on the ulna. In the distal radial ulnar joint, it's a concave surface on the radius, which rolls over the convex surface of the ulna. But in the proximal, we have the convexity of the radial head all the way around, so it's convex on concave. So together, they function as a modified cellar, and they are connected via the interosseous membrane and the annular ligament. The proximal radial ulnar joint, the degree of freedom is 1 because it's pronation supination. The closed pack position is full pronation or supination. and the resting position is mid-pronation to slight pronation. Basically what this means is we cannot have all the joints in the same resting position at the same time. The capsular pattern for the radial ulnar joint is equal limitation of pronation and supination. The normal infield of supination is capsular and pronation is usually capsular. It could be bony, but you don't often get there. We talked about in the pronation and supination, what happens, it's a vertical axis, but as your radius rolls over your ulna, that you end up getting the ulna is in this vertical axis. As the radius rolls over, you get some abduction of your ulna, and as it rolls back, it returns into adduction. So the arthrokinematics and supination, you have an anterior-medial glide of the radial head, because don't forget the radius sits just in front of the ulna, and it's sitting just in front, meaning the joint surface is going to be diagonally. So it's going to be more anterior medially to help supination and more posterior laterally to help pronation, posterior and pronation. So in summary, you can see that the resting positions, maybe we can pull out of this at 70 degrees flexion would give us the most rest for all of the joints, but it's not quite possible to do them all exactly in the same resting position. And the closed back positions as well are not the same. That's the end of the biomechanics. Thank you very much for listening.